So, we are starting the session today.
Okay.
Hello and welcome to one and all. This is Rituparna, the assigned moderator from Clarinet. I wholeheartedly welcome all the delegates across the country. We are really fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking your precious time to join us today. Now, before going deep into the discussion, I would like to take a minute to introduce our platform, Clarinet. Clarinet is India's largest live digital semi platform where doctors can generate their own medical content. Now, I am taking this exciting opportunity to welcome today's eminent speaker, the Master Doctor, Dr. Rohit Kapoor sir. Sir is an MBBS, MD, FNB, MBA, ESFMG from the USA. He is a pediatric hematologist, oncologist, and stem cell transplant specialist. Sir is also a renowned consultant in the Department of Medical Oncology and Hemato-Oncology at Max Super Specialty Hospital, Vaishali. Once again, I welcome all of you at today's lecture for the topic Inborn Errors of Immunity. Now, before starting the session, kindly allow me to give you a brief about today's topic. Inborn errors of immunity, or IEI in short, are mediated by damaging germline variants in single genes. IEI can present clinically as increased susceptibility to infections, autoimmunity, autoinflammatory diseases, allergy, bone marrow failure, and or malignancies. Genetic variants via alteration of the encoded gene product, such as abolishing or reducing protein expression and function, or modifying the protein to acquire gain of function, are responsible for the disease. Now, without any further delay, sir, I would like to hand over the session quickly to you. Kindly proceed with your talk. Over to you, sir.
Okay. Thank you very much, Ritu, for calling me on your platform. As she, Dr. Ritu has already, introduced me. Just a couple of things before I go ahead with my presentation. Inborn errors of immunity are like very, very rare disorders. But the main thing is when we combine it, they may be a lot of disorders altogether. When once you take them at a cumulative, the incidence is pretty high. So inborn errors of immunity were previously called as primary immunodeficiency disorders. And what really happens over here, there is high rate of consanguinity, and it generally happens in genetically isolated population. So basically, there are eight major types of primary immunodeficiency disorders or inborn errors of immunity, which are combined T and B cell, predominantly antibody deficiencies, other well-defined immunodeficiency disorders, disease of immune dysregulation, congenital defects of phagocyte number and function, defects in innate immunity, autoinflammatory disorders, and complement deficiencies. So ESID has, laid down certain things that the general pediatrician needs to see in the child when he or she encounters a kid in the ER or in the OPD. So the child, if he or she is having more than 4 new ear infections within 1 year, or more than 2 serious sinus infections within 1 year, more than 2 months on antibiotics with little effect, more than 2 pneumonias within 1 year, failure of an infant to gain weight or grow normally, recurrent deep skin or organ abscesses, persistent thrush in mouth or fungal infections, need for IV antibiotics to clear infections, more than two deep-seated infections, including septicemia, and if there is a family history of PID, then these are the warning signs that the general pediatrician needs to know, which have been laid up by the European Society of Immunodeficiency Disorders. So this is the major thing. So what do we have to see? The age at presentation. We have to see the pattern of infection. In fact, we have to see what sort of organism you can isolate in the patients who is suffering from PID. There can be non-infectious manifestations. Sometimes autoimmunity can happen, like in ALPS. So family history. So family history of consanguinity and family history of inborn error of immunity is pretty helpful. Most likely it is seen in HLH, like the family history of HLH or multiple abortions may be there. So if there are B cell defects, then the capsulated bacteria are the main culprits, in fact, and these include X-linked A gamma globulinemia, CVID, IgG subclass deficiency, and hyper IgM syndrome, ataxia telangiectasia, and these are the key B cell defects. But sometimes there can be T cell defects, and all sorts of viruses and fungi can infect the patient. So the most common and most studied one is SCID, And generally, initially, it was thought that we can use some gene techniques to fix the skid, but the better results have been seen by transplant, in fact, but it should be done very early. Gene insertions can lead to AMLs or mutational issues and AMLs later on. So, other thing is the neutrophil issues. So, if the patient is having troubles clearing the catalyst positive organisms, like like it is commonly seen in CJD, chronic granulomatous disease. So catalyst positive organisms are unable to be cleared. So there are certain neutrophilic disorders like LAD, leukocyte adhesion deficiency, and chronic granulomatous disease, which I already mentioned, are pretty important in this context. So what are the clues? Predominantly T cell defect. It is very early presentation, 2 to 6 months. Predominantly B cell defect after 5 to 7 months, because the antibodies wane. So, granulocytic defect, they also have an early onset, like CJDs. Complement deficiency can occur at any age. So, if the patient is having combined T and B cell deficiency, the patient would be having all sort of infections, all pyogenic bacterial infections, all sort of viruses, all sort of fungi, mycobacterial, non-tubercular bacterial infections, protozoal infections can happen. Antibody deficiency, more of capsulated organisms, or the organisms, the bacterial organisms can be the main culprits, and the patient can present with skin infection, sepsis, meningitis. Sometimes enteroviral infections can also be the clue, and Giardia lamblia infection in the protozoal is also common in antibody deficiency. In phagocytic deficiency, generally CJD, LAD, in all these things, all these disorders, bacteria, like in CJD, catalyst positive bacteria can be the main culprit, and these like are Staph aureus, Pseudomonas nocardia, S. typhi, and the fungi can also affect the patient. So like Candida as well as Aspergillus, mycobacteria. Infection can also occur, like non-tuberculous bacteria, including sometimes they can present as non-healing BCG thing. So, and skid can present as disseminated BCAGiosis. So, other than that, complement deficiency is basically seen in meningitis, and the patient can present with all meningeal inflammation, and most commonly meningitis related septicemia can happen in these patients. Any sort of viruses can affect, most commonly CMV and HSV. So if there is a predominantly T cell defect, there can be history of GVHD by non-related blood products. The George syndrome, it can present as hypocalcemic tetany. If there is a these are the things that we have to see, like if the thymus is present or not on X-ray. Sometimes thymus is not visualized on X-ray when you are taking a film, which is pretty prominent when the kid is very tiny. So predominantly B cell or antibody defects. So autoimmunity can be there. Lymphoreticular malignancy, lymphoma, thymoma, post-vaccination paralytic polio can happen. Granulocytic defect, LAD, delayed fall of umbilical cord, as well as poor bond healing can be the main thing that we can see. Complement deficiency, all sorts of connective tissue disorders like SLE, vasculitis, dermatomyositis, scleroderma, glomerulonephritis can happen. So what the doctor has to see on the physical examination? If the child is having hypopigmented or sparse hair, Child-Higashi syndrome, Grisly syndrome, cartilage hair hypoplasia can happen. And if there are B cell defects, alopecia, vitiligo, and chronic conjunctivitis can happen. Ocular telangiectasia can be seen in ataxia telangiectasia, oculocutaneous albinism in Child-Higashi, oral ulcer, CJD, SCAD, congenital neutropenia, severe congenital neutropenia. It is also known as Postman syndrome. Gingivitis, commonly periodontitis, stomatitis, neutrophilic disorders, eczema, commonly in BOS, hyper IgE syndrome, hypereosinophilic syndrome, severe dermatitis and Omenn syndrome, erythroderma, skid and Omenn syndrome. So these are the main things. So on physical examination, recurrent abscesses seen in Job syndrome, like hyper IgE syndrome, recurrent granulomas, CJDs, growth hormone deficiency, X-linked gamma globulinemia, bony dysplasias in ADA deficient cartilage, hypoplasia, hypoparathyroidism, and cleft. If they are present and the patient is having, high chance of having the George syndrome, so T cell issues can be there in that. So first line investigations in all PIDs. So CBC differential and immunoglobulin levels and baseline NBT test is needed in any of the PIDs actually. So if the patient, after initial screening, if all these three things are normal, you can go ahead for lymphocyte subset analysis, and Absolute number and relative number of B and T cell can be seen, in fact, and we can ascertain what sort of defect it is. Like, it is a purely B cell defect, it is a T cell, or it's a mixed defect, or there are NK cells that are absent. Or after that, if after basic screening, you can see if there are low T cell counts. We have to uh, see for combined T and B cell defects. If there are low or absent B cells and low immunoglobulin levels and normal T cell defect, it is most commonly antibody deficiency. Abnormal neutrophil count or abnormal neutrophil function, then it is a phagocytic system that is involved. So antibody defects are most common, and X-linked agammaglobulinemia, chronic variable immunodeficiency, selective IgA deficiency, hyper IgM syndrome, IgG subclass deficiency, immunoglobulin heavy and light chain deletion are the predominant antibody deficiency defects, and these are the most common. Now, but all these antibody defects will be presenting with recurrent cyanopulmonary infections, or otitis media, septicemia, diarrhea, and less commonly they can present as enteroviral infection, dermatomyositis, and rheumatoid arthritis like picture. And the key thing is, if the patient is having uh, excessive verruca, then you have to think of X-linked hyper IgM syndrome. Um, so, a quick mention about all of the antibody deficiencies in one slide. If it looks a little busy, but the key thing over here is the symptoms are basically common, and all of them have symptoms once the antibodies wane. But the CVID presents a little bit later. And X-linked agammaglobulinemia, it is important antibody deficiency disorder, and it is a mutation in BTK gene, and it is an X-linked disorder. Thymus is normal, but the kids do not have tonsils. The kids do not have tonsils on examination in X-linked agammaglobulinemia. No lymph nodes are palpable. No, not much role of transplant here in antibody deficiency disorders, but much better role in the patient suffering from T cell immunodeficiency, in which the role of transplant is much more, data is much more. So in CVID, we can see there is switching of the class switching defect is there. It can present a little bit later, but the T cell subset and function is normal, and a B cell number can be normal, but the function is not that good. So immunoglobulins, because it's an antibody deficiency, there are no immunoglobulins. Cancer risk is high. Autoimmunity is high because B cells are making all sort of immunoglobulins that are not like not much screened by the body, and it can lead to autoimmune disorders. Amyloidosis is there. Family history of IgA deficiency can be seen. Hematopoietic stem cell transplant is beneficial, but the main thing is the mortality can happen if there is an active infection which is ongoing, in fact. So, coming to selective IgA deficiency, it's autosomal dominant and IgA levels are low. The patient can present with celiac disease. And fatal reaction can happen with any kind of blood transfusion. Sometimes IVIG can also lead to transfusion reaction, because sometimes they have a little bit of IgE. Hyper IgM syndrome, again defect in class switching. Like, it is of 5 types, and CD40 ligand gene mutation, AID coding gene mutation, CD40 gene coding mutation, uracil DNA glycosylase coding gene mutation. Tonsils are again absent, like in type 1 and 2, but they are enlarged in 2 and 5. In hyper IgM syndrome, due to CD40 deficiency, it can be cured by a stem cell transplant. So what are the investigations in predominantly antibody deficiency? Just go for B cell number by flow. If only one investigation need to be done, and immunoglobulin levels, you already know you need to do it. Basic DLC can help. Um, Sometimes pre and post immunization levels after giving vaccination you can do to see what is going on, whether they're appropriate antibody production or not. So again, after doing some basic tests, we can see, based upon the lymphocyte subset analysis, what sort of antibody deficiency it is. But there's a catch. Like in hyper IgM syndrome, there are markedly low IgG and IgA, but there are normal or high IgM levels. An expression of CD40 and CD40 ligand on B and T cells, you know, we have to see by flow cytometry whether it is there or not. But the IgG and IgA levels are pretty low. but the IgM levels are very high. So sometimes autoimmunity is there. Some autoimmune hemolytic anemia or cold agglutinin disease can happen in this. So coming to the most important one, the SCID. SCID can be divided into T cell positive SCID and T cell negative SCID. And reticular dysgenesis is also kind of a very severe immunodeficiency at the level of stem cells. So reticular dysgenesis, very sick kid having both immunodeficiencies B and T, and at the level of stem cells, and there is adenylate kinase deficiency, and it is much more treated as like a SCID variant, and management is like SCID only. The treatment for all these things is basically stem cell transplant. So coming to the quick division, T cells SCID, the T cells are always involved, but sometimes T cells are present, but that is leaky SCID, and it is seen in like Omen syndrome, and the patient generally is seen as a tiny baby with the erythroderma, and the kid is very very sick. If the T cells kid is there, and there is concomitant presence of B cells, and there is presence of NK cells, then it is most likely IL-7 alpha deficiency, and it's a mutation, and in a gene that codes for this IL-7 alpha receptor. And so if the B cells are present and the NK cells are absent, then it is X-linked recessive SID, which is the most common interleukin 2 receptor related mutation. And if the T cells are absent along with the B cells which are present, and NK cells are absent, and it can also occur as an autosomal variant, which is a JAK3 mutation, and it is also the presentation of all these are like significant sick baby, and these patients have both component of sometimes bacterial, viral, fungal infections, both, but more severe viral as well as more severe fungal infections can also happen in these patients, and these patients generally have disseminated BCG-osis, which is the first catch. So now, as I already mentioned in the above figure, interleukin 2 receptor mutation, which is the X-linked recessive SCID, is the most common, which is the 47% of the cases, and the treatment is stem cell transplant. And the main thing over here is you cannot be much intense in the stem cell transplant practically, because these patients are already kind of very, very immunocompromised, and if you give a lot of conditioning, then infection flare can happen, and probably they can die of sepsis. So the main thing is sometimes in these cases, if the previous trials which were done were that they didn't even give any kind of conditioning, and they did a match sibling donor stem cell infusion directly, and the T cells from the donor recipient who was actually matched, like engrafted and produced the cells actually, in fact. So sometimes no conditioning is needed if the baby is very sick, and these babies are very tiny, like around 6 months of age. So now different varieties of the other SCID. ADA deficient SCID, you can give some enzyme actually, some pegylated ADA enzyme. So it is like not that much easily available in India, but in fact it can be given until the patient is still deciding, or we are searching for a donor for stem cell transplant. The patient is having all the vitamin D deficiency kind of symptoms, and there is delayed development, and seizures, deafness, lymphopenia, all these symptoms can be there. In purine nucleophosphorylase deficiency, so there are much more trouble in the brain actually. So behavioral anomalies, tremors, hyperreflexia, hyporeflexia, spasticity can be there. Developmental delay can be there. Behavioral disturbances can be there. Omen syndrome is basically a leaky skin, and the patient, as I already told, presents with hepatosplenomegaly, erythroderma, T cell infiltration of the skin, liver, spleen, as well as intestine. It's rare. A lot of eosinophilia is there, and the mom and dad think that maybe the child is having some milk allergy, and in fact it is Omen. So Artemis deficiency is also kind of scared, and it has a high radiation sensitivity of skin fibroblasts and bone marrow cells. RAG2 and RAG1 and RAG2 mutations, they have a lot of eosinophilia and lymphocytosis. So, but none of the lymphocytes are working that well to fix the infection. So T cell positive SCID. So just see for these are the differentials: MHC2 deficiency, ZAP70, MHC1 Omen, and you need to see the T cell proliferation assays, expression of HLA DR on T and B cells, and in fact TCR receptor analysis has to be done actually, and all of these are the molecular analysis, and can be practically done by flow. So the presentation is failure to thrive, chronic diarrhea, persistent thrush, skin rash, pneumonia, early death, disseminated BCG infection, and practical all of these except for women, which is a little bit different. And there is no thymus, generally tiny thymus in all T cells. So early death can be there, and if you give some blood to them, they can die of GVHD, because the T cells from the donor blood, or the cells which are in the donor as a contaminant, they can just engraft in the bone marrow, and they can cause GVHD. So combined labs labs in combined immunodeficiency is like just one catch. Just get the lymphocyte, some subset analysis, and you are there. If the B cells are low, B cell deficiency. T cells are low, T cell deficiency. Subset analysis can also be done to see for like individually CD4 deficiency, like T cell deficiency disorder. Subset analysis can be done actually. And track T cell receptor excision circles can be done actually as well. So to detect at birth, actually, you can screen at birth. So now coming to well-defined PIDs: viscochildred syndrome, DiGeorge syndrome, ataxia telangiectasia, hyper IgE syndrome. So WAS, important one: males, small platelets, a lot of eczema, allergies, molluscums, pneumocystis carinii infection, herpes infection, X-linked recessive thing, lot of risk of malignancy, EBV disorders. Just treat by giving, you have to give some killed vaccines to fix certain infections that can be prevented. And in fact, these kids, have rash, eczema, a lot of thrombocytopenia, microplatelets, treat with stem cell transplant. So this is what a kid looks like. Some petechia there, and ecchymosis, some orbital ecchymosis, some eczema, a male guy. So DiGeorge syndrome, as we already know, actually, as I discussed, it's a velocardiofacial syndrome, conotruncal anomaly phase syndrome, and there are micro deletions. In fact, in this syndrome can happen actually, and you can see for absence of thymus or aplasia of thymus, an absolute lymphocyte count and T cell lymphocyte analysis can be done. You can see the child is having some sort of a cardiac anomaly, conotruncal anomaly, abnormal faces, thymic hyperplasia, cleft palate, can have hypocalcemic seizures, and sometimes can present as charge in one third of the patients with, if there is CSD7 gene mutation. And the treatment can be thymic transplant, but in fact it is not easily available, so stem cell transplant can be done in DiGeorge syndrome. But the thing is, sometimes T cell reconstitution cannot happen sometimes. So this is a DiGeorge kid. And hyper IgE syndrome, which is known as Job syndrome, which is autosomal dominant version. STAT3 gene mutation is there. Staph abscesses are there. Fungal infections are there. A lot of eosinophilic pustules in newborns can happen. Pruritic dermatitis, abnormal facies are there, like all sort of dysmorphic facies. Coronary artery toxicity can be seen. Aneurysm early in life can be seen. In all of them, more, including the autosomal recessive hyper IgE syndrome, which is a docket mutation. Generally the kids present with severe allergic issues, severe asthma, food allergies, anaphylaxis, pruritus, increased tendency to develop lymphomas, all these things. So just do again, the lymphocyte subset analysis, and just see IgE levels. So over here we can see a lot of molluscum, and over in the figure, allergies, atopy on the left side, and molluscum contagiosum on the right. So ataxia telangiectasia gene mutation is ATM gene. There is variable immunodeficiency, most common IgA deficiency is there. Cerebral ataxia is there. Recurrent chronic sinopulmonary infections are there. Fatal varicella is there. Uh, you know, the transplant can be done, but the main thing is it would only fix the immunodeficiency component. So it would not fully fix the other symptoms. The non-hematological things cannot be fixed. So as we can see, telangiectasias in the conjunctiva as well as the the cheek, which are visible here. So phagocytic defects include LAT, leukocyte adhesion deficiency, CJD, MPO, myeloperoxidase deficiency, Chitikagashi syndrome, severe congenital neutropenia. The LAD has three types: type 1, type 2, and type 3. The main thing is the pus, which is absent in all these things. Adhesion is not there, there is no pus, and the healing is effected in all three. A little bit things are different in type 1. There is delayed separation of umbilical cord. In type 2, there are sometimes fatal reactions after blood transfusion, like Bombay antigen. There is absence of AB antigen on RBCs. This is a type 2 kind of thing that we can see in leukocyte adhesion deficiency. In type 3, there is kindlin 3 mutation, and Glanzmann type of bleeding can be there, and there is severe gingivitis, early teeth loss, and you know we can cure LED type 1 as well as 3 by stem cell transplant, and we can use reduced intensity conditioning because they are practically already infected. So a little bit mixed chimerism is okay in these patients. So this is delayed separation of umbilical cord, which is seen in LED type 1. Chronic granulomatous disease, as I already told, catalase positive organisms are the main culprit over here. That and there is defect in the NADPH oxidase, any of the subunit, and depending upon the gene that is mutated, and you can see what sort of subunit may be affected, and that can lead to multiple infections by catalase positive organism. A lot of lymphadenopathy, a lot of hepatosplenomegaly, pyloric outlet narrowing, a lot of granulomas here and there. HLH can happen. The treatment is stem cell transplant. So these are the chronic granulomas, as we can see, and there some of them are draining, in fact. So this is a classical presentation of CJD. MPO deficiency, it is autosomal recessive disorder. It can present with disseminated candidiasis, and sometimes there is a green pigment which is generally present in the neutrophil. That is it is the myeloperoxidase actually enzyme that imparts the the color to the pus actually. So we can also see these patients have a lot of pustules, that are non-healing, and these patients are pretty very sick. Actually, they present with sepsis, in fact, and they have to be treated. They can be treated by stem cell transplant. In fact, Chideke-Kashi syndrome, there is a mutation in NYST gene, and this basically gene regulates vesicle formation. There are a lot of hair anomalies, oculocutaneous albinism is there, neuropathy, ataxia is there, bleeding tendencies there. The patient can present with HLH. Hematopoietic stem cell transplant is curative. So this is a classic patient with Chideke-Kashi syndrome. So labs, you can do just full flow cytometry to diagnose any of the lead. Any of the leukocyte adhesion defects can be diagnosed by flow. CJD can be diagnosed by NBT or DHR or flow. So flow can diagnose anything. So again, after the flow analysis, you can do a genetic analysis, in fact, and you can directly hit the probe using the probes at a particular set of genes, in fact. And CJD classic test are NBT test and the DHR test, in fact, that can be done. So now coming to disease of immune dysregulation, these include familial HLH, ALPS, APEX. So ALPS is familial HLH can most commonly is due to the perforin gene mutation. ALPS is basically autoimmune lymphoproliferative syndrome. And APEX syndrome is immune dysregulation, polyendocrinopathy, enteropathy, X-linked syndrome, in fact, and a lot of autoimmune cytopenias are there. Primary HLH, very sick patient, lot of fevers, big spleen, marrow, lymph node, liver involvement, early aged presentation is there in the familial cases, lot of cytopenias, hemophagocytosis is there, treatment is stem cell transplant. ALPS, again, disorder of lymphocyte apoptosis. The patients have a lot of cytopenias actually, they can have hypersplenism, autoimmune hemolytic anemia, events, neoplasms can be there, lymphomas, thyroid, skin, lung, heart tumors can be there, vasculitis, arthritis can be there. In fact, hematopoietic stem cell transplantation is curative. So coming to the stem cell transplant in primary immunodeficiency disorders or inborn error of immunity. So the main thing is that you can only fix the hematopoietic component. You cannot fix the extra hematopoietic component or the CNS or any liver or any other component. Like you cannot fix ataxia, you cannot fix all these telangiectasias. You can only fix the IgA component, like the immunity related component, not other than that. It would only fix that. So if the thymus is involved, so the main thing is the stem cells, once they are given, they go back to thymus as well as the marrow. But in fact, if there is a thymal stromal defect, again the T cell reconstitution cannot be guaranteed. So again, you can see it by a lymphocyte subset analysis. So you have to see for the donor. First of all, if the patient is suffering from immunodeficiency disorder, there is high history of consanguinity, and the donor may also be carrying the same gene. So if you give the same gene to the recipient, in fact, that can be a big trouble, most commonly in HLH and all these carrier X-linked recessive carriers. This can happen, in fact. So the genotype and the donor assessment is important. Now actually, if there is no match sibling donor, we can do haploidentical transplant, and we can do an ex vivo depletion of alpha beta T lymphocytes, and sometimes we can do a T cell replete mismatch transplant, and we can use post transplant cyclophosphamide after the graft infusion. So we can go ahead with the flu-cy, fludarabine cyclophosphamide, which is a decreased toxicity, or RTC, reduced toxicity regimen. Or we can go ahead with the triosulfan-based conditioning with a standard graft versus host disease prophylaxis by cyclosporin A or tacrolimus in combination with methotrexate or MMF. And we can also add some serotherapy like ATG or anti-CD52, which is alemtuzumab, for in vivo T cell depletion. So the main thing is low intensity, reduced toxicity regimens, because they are probably infected and they can probably die because of sepsis even during the engraftment phase, in fact. And the GVHD prophylaxis is like a lymphodepletion. So, in fact, all old lymphocytes need to be wiped. So, this can be by ATG or Campath. Campath is used in UK, ATG most commonly used in this US, um, and even in India. So HSCT is curative in these disorders, as you can see, and which I have already discussed above. And these most important one of these are the the SCID, LADs, CJDs, WAS, which are common, HLH. These are curative. HSCT is controversial in certain disorders like DiGeorge, in fact, because the thymus will not is absent, and there can be no T cell reconstitution. So now again, if we go at the conditioning regimen, there can be a protocol-based toxicity or protocol-based GVL related or graft versus host, or host versus graft disease. So we have to decide among the RTC, not MAC or non-myeloablative. Sometimes we can give a non-myeloablative regimen, but then we have to see the general status of the child, whether the child would be able to tolerate the non-myeloablative regimen. So we most commonly go with the reduced toxicity regimen, and the commonly used regimen are the flu trio or fludarabine triosulfan or mel flu based transplant regimen. So these are the key ones actually we tend to use. We generally don't tend to use the flu, bu, TBI or all these set of regimen, because they are very significant. The patient become very sick. So protocol are, as I already mentioned, you can the one of the best protocols would be the flu trio based regimen. And if we give more and more myeloablation like trio brew based, then the main thing is a lot of toxicity. They are already immunocompromised, they can die. So probably you have to keep the myeloablation in the mid. So trio brew with low dose brew, and flu mel and flu cy are the key ones here. So if we go ahead, except for terrible situations like HLH, you have to myeloablate the marrow. So the patient will, in any case, will can die. Actually, the HLH is a significant emergency, and if the immune system is not ablated completely, the child can die. So you have to give a the regimen which is myeloablative with lymphodepletion. So few with few 160 mg per meter square, and BU around 90 mg per kg. So you have to go for it. So otherwise the child will not survive. In fact, so the main thing is the issue with BU is the VOD, which is less as compared to and in trio it is less. So better conditioning regimens are the RIC or RIX, or we can use the Flumel or Buflu or Trioflu. So now coming to the amount of stem cells, if you can give in the cases of IEI. So if it is like match-related donor, the less number of stem cells would be okay. If there is MUT, so less number of stem cells would be okay. But if it is a T cell depletion, you have to give mega cell dose, because sometimes the T cell depletion or depleted marrow, if you infuse, there would be no GVHD, but sometimes there is no engraftment or the stem cells will go in the marrow, but will not function. So the main thing is you can use the cord blood unit, in fact, but a cord blood engraftment is delayed and the child can die of sepsis. So the cord unit engrafts in around 45 days. So GVHD prophylaxis, I already mentioned, like you can use methotrexate, calcineurin inhibitors, corticosteroids, all these things, in vivo depletion by Campath, or which is also known as alemtuzumab, or ATG, or ex vivo depletion. So other GVHD therapies can be, interleukin 2, anti-interleukin 2 are a receptor antagonist. In fact, it is like all those basiliximab, infliximab, etanercept, and all those things. So we can use. So these are the things that we can use. And in fact, now transplant, coming to the transplant in individual immunodeficiency disorders, like in SCID. So earlier you transplant, better is the outcome. Overall survival has increased, in fact. And the best is like match sibling donor is the key. And if the match sibling donor is there, then you can directly use the stem cells of the match sibling donor and can give to the SCID patient, so that there can be rapid development of T and B cell function post stem cell transplant. But the main thing is the T cell of the donor, they exist, but the myeloid as well as erythroid origin cells, they remain of the recipient origin. Conditioning or GVHD prophylaxis is recommended in unrelated donor. So however, there is acute GVHD, increased acute GVHD, inferior B cell immune reconstitution in unrelated donors, in fact. So mismatch related donors, in fact, you can use a peripheral stem cell source, you can use a bone marrow stem cell source, and in the cases of haplo, you can go out for post transplant cyclophosphamide. So this is actually already discussed like above, in fact, and TCR alpha beta depletion, is one of the best things, but it is very expensive. Like, it is not easily available in India, but the PTCI approach can be done. So post-transplant cyclophosphamide is a cheap option with good set of engraftment, good low incidence of GVHD, low toxicity can be there if the mom and dad are the donor for the kid. So unrelated cord blood donor, the GVHD risk in the cord blood is less, but there is lower in engraftment, and sometimes there is a stem donor lymphocyte infusion boost, which can be given post transplant to attain chimerism. If there is a falling chimerism, then you can use you cannot use a donor lymphocyte infusion. Oman syndrome, lot of troubles. Transplant can be done, lot of mortality. Conditioning is mandatory, and like midway conditioning, you have to give like a reduced intensity conditioning, high rate of endothelial toxicities. We have to give defibrotide. So so this is the genotype related conditioning regimens in each of these SCID, as you can see, and most of them are RIC, or like kind of RIC or non-myeloablative you have to go for. So enzyme replacement therapy is an option for ADA deficient SCID. It can be used as a bridge to stem cell curative therapy. And in transplant in non-SCID patients, you have to give conventional, sometimes MAC regimen if the child is pretty sick, like in cases of HLH. And the main thing is these kids tend to do better on flu-cy and trio flu based regimen, because trio is a good immunomodulator and immunosuppressant, and that's the main important thing in the cases of, in these disorder we can use triosulfan. So good survival rates have been seen, and especially in the patients with the CJDs, good set of survivals can be seen even if there is a mixed chimerism, even if some more than 50% of the donor cells are present. So coming to the Viscott-Eldred syndrome, HSCT is curative, and high intensity conditioning regimen can be used if there is no active infection, followed by reduced intensity conditioning. CJD, again, it is also curative. The HSCT is curative in these cases, and even the little mixed chimerism would protect against the infection. In fact, serotherapy by alemtuzumab, ALTG, ATG is recommended. Sorry. So HLH, the basic thing is the disease remission at the time of stem cell transplant. So main thing is reduced toxicity conditioning protocols, and if the disease is controlled, and sometimes high intensity conditioning may be needed if the disease is uncontrolled. So little bit T cell chimerism is sufficient to protect against the disease relapse. Sorry. So sometimes gene therapy can be given for specific immune deficiencies, and autologous gene stem cell transfer can be done. And first licensed gene therapy for PID was done for ADA deficient SCID. Gamma retroviral can be used in ADS kid, X-linked kids, chronic granulomatous disease, Biscott-Eldred syndrome, and gene therapy can be effective option in the patients lacking HLA identical donor. So again, a lot of issues are there. Sometimes insertional mutagenesis can happen in these patients, and these patients can end up having AML or something like that. So autologous gene therapy is a good option, very expensive option, but there would be no GVHD, no graft versus host disease, because it's autologous stem cells that are modified by the viral, the uh, carriers that insert gene into the stem cells. Lower set of conditioning is given to sustain engraftment, and there are certain new targeted therapies like ruxolitinib, leniolisib, etanercept, and IL-1 directed therapies that have come up. So quick take-home messages are that the most PIDs are due to the genetic defects, and full or partial ablation of the recipient marrow with chemotherapy is needed in certain set of PIDs if the patient is not very sick. If the sorry yeah If the patient is not sick, but the CO therapy may be added to decrease the incidence of graft rejection and graft versus host disease. An outcome of hematopoietic stem cell transfer for PID has significantly improved due to the high resolution HLA typing, presence of alternate donors like haploidentical donors, new stem cell sources, reduced toxicity and intensity regimen. GVHD prophylaxis in the mass sibling donor would be the methotrexate as the cyclosporin A, or sometimes in haploidentical donors, post-transplant cyclophosphamide or tacrolimus can be used as a GVHD prophylaxis, and you can add MMF on the top of it, and eventually you can withdraw MMF around day 35. ATG you have to add to decrease the GVHD risk, or sometimes in UK the protocols they tend to add Campath. And the main thing is the PID patient should be early referred, early treated, because good results are there if the transplant are done pretty early. So if there are any questions, actually, I would like to answer those questions that might have come up during the presentation, in fact. And over to you, Ritu.
Thank you very much, sir, for this enlightening presentation. It was really elaborative and lucid. So, with all your permission, sir, can I put across the questions as posted by our doctors?
Yeah, for sure.
So, sure, for the timing, can I stop the screen sharing from my end? Okay. So, the very first question is asked by Dr. Rahul Agarwal. He is asking, how does the study of inborn errors of immunity contribute to our broader understanding of the immune system?
Okay, so Joe, the inborn errors of immunity, are the conditions, in fact, in which the immune system is like not that well developed, in fact, and there are certain genetic defects, that may cause the patient to present with atypical infections. So main thing is the immune system is has mechanisms to take care of infections and do some immune surveillance and prevent autoimmunity. So the main thing in inborn error of immunity, you would be seeing the kids that present very early. They have all sort of weird infections, not regular infections, and the infections appear at particular points of time. So if the child present with infections earlier, like less than 6 months, they are most likely T cell related. Okay, if the infections occur like around more than 6 months of age, then they are most likely due to the waning of the maternal antibodies, which are protected to the kid. Most of them, if as a pediatrician or a general medicine practitioner, you will see that these babies have history, the family, there is a family history of some sort of repeated abortions, or there is history of consanguinity that may be present. The key thing is you have to understand that if the child is presenting with a weird infection, a lot of antibiotics are given, a lot of supportive care is given, is not improving, it's likely the immune system that is not functional, and the child needs to be referred for earlier for transplant if it is feasible. Ritu, over to you.
Thank you very much, sir. So, can we move ahead with the next question now, sir?
Yeah, sure.
The next question is asked by Dr. V.K. Agarwal. He is asking, are inborn errors of immunity typically inherited in an autosomal dominant or recessive manner?
So the inborn errors of immunity can be inherited in either of ways. Actually, they can be even X-linked. So they can be autosomal dominant sometimes in Job syndrome, which is hyper IgE syndrome. It is autosomal dominant. Okay, so mom and dad may also be having recurrent staph infection. The kid also is having recurrent staph infection, which are not, being cured. Lot of IgE levels high can be there in this condition. Coming to like the X-linked recessive, X-linked recessive, it can be seen in SCID, which I already mentioned, and sometimes in VOS, viscoelastic syndrome. Most commonly, although these conditions are like related to consanguinity, they commonly are like recessive. So autosomal recessive inheritance is the most common pointer that, and there is a history of consanguinity that the kids they present with all sort of rare autoimmune disorders. So extinct recessive are autosomal recessive are many, and the key thing over here is that we need to see in the history and examination is recurrent infections and the type of infections that can lead to clue whether it's a B cell, T cell, or a phagocytic defect that would lead to further treatment and management based upon, and then you would be able to order certain set of labs based upon the initial presentation. Okay, Ritu.
Thank you very much, sir. So, with all your permission, now moving ahead with the next question. So, the next question is asked by Dr. Nehal Patel, and she is asking, are combination therapies commonly employed in GVHD prophylaxis, and what are the considerations when combining different agents?
So this question is a good question. In fact, actually, the main thing is the stem cell transplant is practically curative in most of the immunodeficiency disorders, and since the the donor and recipient have before the transplantation happens, we have to do a pre-transplant workup in which we match the HLA, and the HLA should be best HLA match should be of a match sibling donor. So there would be practically very less incidence of graft versus host disease because you are matching like the 12 by 12 match by using next generation sequencing. If it is fully matched, then the chances of graft versus host disease are less. So less match means more chances of developing the graft versus host disease. So what do we have to do? We do not want any kind of graft versus host disease. We do not want the donor cells to fight with the host and cause all sort of rash, jaundice, diarrhea, and all these things. So we need to control the donor cells, haploid activation. So haploid activation can be controlled by using cytotoxic agents. So cytotoxic agents in match sibling donor are methotrexate. It is cyclosporin, which suppresses T cells. And if there is a unrelated donor, whether you are getting a cord blood or you are getting a the stem cell product from different countries, which is match unrelated donor mud match. So you need to add some ATG or you have to add alemtuzumab to wipe the T cells, so that there is no GVSD in fact, and it is known as in vivo T cell depletion. So other cheaper option is post transplant cyclophosphamide, which is like done in the patients with if there are no donors, and the post-transplant cyclophosphamide is done in the haploidentical setting. So mom and dad can be the donor even if they're half match. So you can give a very strong GVSD prophylaxis with a combination of post-transplant cyclophosphamide, tacrolimus, and mycophenolate mofetil. So these are the three set of medications that can be continued as a GVSD prophylaxis, which is immediately necessary because acute GVSD is a very high mortality, like more than 50 to 60% mortality. And if it happens, you have to start with pulse steroids, and you have to sometimes give etanercept, you have to give infliximab, you have to give methotrexate, and sometimes horse ATG or maybe rabbit ATG may be needed to control the acute flare. New agents like have come like abatacept, but the thing is we are still limiting abatacept in the Indian setting because the data is emerging. So this is like for the graft versus host disease. Over to Ritu.
Thank you very much, sir. So now moving on to the next question. So the next question is asked by Dr. Vitul Mishra. He is asking, how does genetic counseling play a role in families affected by inborn errors of immunity?
So, as I already told, that there is a history of a lot of consanguinity. Actually, it is like pretty common in even South India. It is common in Middle India. Consanguineous marriage can happen in closed communities, like outside India in Jews. Like so, certain disorders, they tend to cluster because of the autosomal recessive nature. In fact, and they tend to present, because the gene clustering can happen. So the main thing over here is genetic counseling is that if there is a family history of autoimmunity or weird disorders or weird infections, the patient should uh, consider genetic counseling. In fact, if there is a family history of a lot of deaths in the in the past, in fact, and history of infant dying with a lot of infections, you have to need to ask in the history. So if these are present, then you have to counsel the parents that you can go ahead with the next pregnancy, but we need to do chronic villus sampling or amniotic fluid aspiration to see whether the child is a carrier or it is a homozygous condition, or it's a X-linked disorder which is being carried, that can be detected by NGS, next generation sequencing, or the DNA based techniques from the amniotic fluid as well as chronic venous sampling. And we can make sure that the child does not have any kind of immunodeficiencies. These things are like not foolproof. However, but if there is a history of recurrent abortions or stillbirths or all these things, so better to perform these tests rather than giving birth to a child who is suffering from such a significant disorder that may be, traumatic to the, mom and dad as well. So genetic counseling really plays a role. Consanguinity should be avoided, in fact, and clustering of the various families and subgroups, it should be avoided because it can lead to these fatal conditions, in fact. So what do you Ritu?
Thank you very much, sir, for answering all the queries of our doctors. And I would also like to thank all the participating doctors for their continuous participation at our platform and sharing such valuable insights. And before we finally close, I would like to request all the participating doctors to suggest any other different topic based on this particular specialty. And we would be very glad to conduct a session on this platform with your suggested topic. Indeed, sir, this lecture is going to be very useful for our audience in their future endeavors. So, with all your permission, dear doctors, we are signing off for today and hope to see you soon at our platform with the next interesting topic. Till then, stay safe and healthy and have a nice day. So, before we close, as requested to you, if you have time, can we go ahead with the case discussion?
Yeah, for sure.
Okay, sir. So, let me share the screen first to you. So, here is the case. You can
Hmm.
have a go through
Yeah.
over it and then you can go ahead if possible, sir.
Yeah, so we have a 2 year old tiny infant and with a 2 week history of anorexia, malaise, fever, and abdominal pain, seen by several physicians who treated for him for fever, antibiotics, antipyretics without much improvement. On admission, his temperature was 38.9, his pulse was 110 per minute, and BP was 97 by 65. Physical examination revealed a weak, dehydrated infant. The baby was less than 50 percentile for his age. Abdominal examination showed tenderness on the right side of his abdomen with enlarged liver. Auscultation of the chest was normal, and rest of the physical examination was within normal limits. The lab showed HB of 9.5, WBC with a normal differential and a normal platelet. Urine and serum electrolytes were normal, and upon admission, the infant was started on intravenous fluids. Empirical third generation cephalosporin was given. Few hours later, the child developed sudden onset respiratory distress with severe tachycardia. X-ray revealed opacification of the right hemithorax. Chest tube was inserted. However, it failed to relieve the infant and it did not yield any fluid. Small amount of the thick membrane-like material was obtained, which was sent for analysis. Okay. And due to this continuing respiratory distress, the infant was taken for surgery, and a right limited thoracotomy was performed, and it revealed a ruptured liver abscess into the chest. A thick, cheesy material was evacuated, and two large chest tubes were left to drain the chest cavity. A rupture was seen through the cupula of the right diaphragm, through thought to be amoebic liver abscess, through the diaphragm into the chest, and computed CT scan uh, showed a large abscess cavity. So, quite a good case, a summary. In fact, the main thing over here is the liver abscess in such a tiny baby. Since over here the first screening thing was the CBC had a normal differential. So if the CBC has a normal differential count, then we have to look more towards the infective etiology. You can over here in this case you can start empirical agents that would cover for even gram positive organisms. You can cover for anti amoebic organisms, and you can even do a workup for chronic granulomatous disease if there are a little bit lymph nodes over there, because the CJDs can present with a lot of abscesses with gram positive organisms. In fact, if the abscesses occur and the child is not responding to the higher set of antibiotics, you need to send a pus culture and sensitivity, and you can do a screening NBT test to make sure that there is no CJD. You sometimes a lot of protozoal infections can also occur in the babies, but the incidence of these sort of infection is pretty less. The amoebic liver abscess is less in this age group. So first of all, if I summarize the treatment plan, that liver abscess can be can be a pyogenic liver abscess or amoebic liver abscess. You have to cover for gram positive organisms. You can like avoid like targocid, in fact, or ticoplanin, because it can sometimes derange LFTs. You can use cloxacillin. You can use basic set of antibiotics if you are in a government setting, like MP clox and or claf. And along with that, you can add metrogel, or you can add anti-amoebic agents in this. You can send a pus culture sensitivity. You can send a CB nat to cover for to see for any kind of tubercular infection as well. You can also do a stool analysis of the child, and the main thing over here is the you can do a NBT test to make sure that there is no chronic granulomatous disease as well, because it's a very large abscess cavity. So this is the main thing. And uh, the once the reports are there, then we would be in a better position to see what exactly we can do best for the kid. Any questions from the doctor who has presented this?
No, sir, no further questions we have, but thank you very much, sir, for sharing your expertise in this case. It will be very beneficial for the doctor who has sent this or posted this query. So, thank you once again, sir, for being with us and spending your valuable time with us. So, looking forward to host you again very soon. Thank you very much, sir, for your time and effort. Thank you. Have a good day, sir. Good night. So, with all your due permission, we are signing off for today, sir.
Thank you. Thank you.
Thank you, sir.